Then there is a continuous mandatory ventilation. It is also called the complete control of the mechanical ventilation. Here the rate is set. The inspiratory expiratory ratio. Normally our inspiratory expiratory ratio is 1 is to 2. So the ratio is set to 1 is to 2. The volume is determined entirely by the machine and cannot be altered by patient's effort. So usually if I have to use this mode, I need a patient who is reasonably sedated and paralyzed perhaps at times. So that paralyzed means using muscle relaxants, I'm saying, not paralyzed because of some neurological condition, but using muscle relaxants so that I can actually effectively take care of full ventilation of this patient. I can give a set tidal volume at a set rate, at a set I ratio, at a set FiO2. Okay, the patient does not have any control. Everything is controlled by us. You could relate this type of a setting to a anesthesia setting. So if you have a major surgical procedure going on, this is what usually the anesthetists do. They completely sedate you so that you are not aware of what is happening, and then they give you some muscle relaxant so that the muscles are basically relaxed. You are not taking any breaths on your own, and the entire job is done by the ventilator or the anesthesia machine in the operation theater, and the surgeon gets a good operating field, a relaxed muscle field, so that they can stretch the muscles of whatever area they are operating on and do their job to the perfection. So that's the most best analogy which I can give. Then there would be something called as an assist control. Okay, so assist control is in addition to a preset number of mandatory breaths, the ventilator delivers additional full breaths whenever the patient has a spontaneous respiratory effort. So the ventilator, as the name would say, tries to assist. So there is a control on the ventilation, but there is also an assist mode to it. Okay, and that assist mode is essentially sensitive to the trigger. So you need to set up a trigger, that what trigger should the ventilator start assisting it. So that's called as an assist control mode. Okay, so this is what sort of the assist control mode is. You have an assisted breath. You can see that the patient's breath sort of went below the baseline. The trigger was sensed, so you have a assisted breath. Whereas this is a completely controlled breath. Here the patient did not trigger at all, and you would have a controlled breath here. So similarly, you can sort of look into the mechanics on a volume control, volume chart as well. Then you have an intermittent mandatory ventilations. Well, patient is allowed to take spontaneous breaths in between the preset ventilator breaths. Problematic mode, it's not used that much just as a intermittent mandatory mode, but sometimes you can actually use it as a synchronized intermittent mandatory mode. So you have a ventilatory breath, and then you have a number of spontaneous breaths in between, and you could have the stacking of the breaths, which is you can see here on the volume. So small tidal volumes are generated, whereas your actual need is up to here, but you are generating very small tidal volumes. So to overcome that, what the new ventilators do is they have something called as a synchronized intermittent mandatory ventilation. So every time a patient's breath is noted by the ventilator will try and give a full support at that breath. It basically allows the patient to breathe and have mandatory breaths as well. So it essentially gives you a spontaneous breathing outside the sensitive periods at times. So this is what synchronized intermittent mandatory ventilation would mean. You would have a ventilatory controlled breath and you would have ventilatory assisted breath. But intermittently, you could still have small short breaths which are going on. Now, what is a trigger? The trigger is essentially the ventilator knows when to give a breath. That is what is called the trigger. So you can either set it up as a change in the pressure or a change in the flow, and essentially that's how the ventilator would sort of do. Most of the time, it sort of looks at the change in the pressure and goes accordingly. Okay. Now the patient determines the respiratory rate, ventilatory volume, and inspiratory time in a mode which is called as the pressure support mode. So here everything is done by the ventilator, and it's a purely a sorry everything is done by a patient, and here it's a purely a spontaneous breathing mode. So patient triggers his own breath. It is limited by the pressure, but it essentially allows the patient to take its own breath without the ventilator trying to force a breath on itself. Okay. Now, from a volume control, you come to a pressure control. So I told you that there would be a set volume and there would be a set pressure. Here, the ventilator determines the inspiratory pressure. There is no patient participation in this. Okay. The parameters are triggered by time and limited by pressure, and it will affect only the inspiratory part. Obviously, you can't keep a pressure apart from a PEEP at the end of expiration. So in the expiratory part, there is no pressure. Okay. However, because the pressure may keep on changing according to the compliance of the lung, you may actually have to adjust frequently to try and maintain an adequate tidal volume. Okay. So a patient with non-compliant lung may require alterations in the inspiratory time to achieve a adequate tidal volume, or inspiratory pressure to adequate tidal volume, to achieve an adequate tidal volume. PEEP, I've already told you that little pressure which you apply at the end of the balloon when you're trying to inflate a balloon. This is basically what the PEEP does. It is used to help prevent the alveoli collapse at the end of expiration. It can be used basically to keep up the airway open. Now, is it that simple that if I just say that give PEEP and the alveoli will remain open? It's not. You can increase the PEEP and you may possibly increase the dead space. You may possibly decrease the cardiac output, and you may sometimes even worsen the VQ mismatch. I'll just take a minute to explain that. Let's say if I have my capillary here and I'm applying a PEEP of 40 or 50, okay, and I have an inspiratory pressure which is around 20 already. So my total peak inspiratory pressure is going above, well above 30-35. My cardiac output is also dependent on the amount of intrathoracic pressure I have in each breath. Well, if I have very high intrathoracic pressure, much higher than my right ventricular pressure, my right ventricular pressure is somewhere around 20 to 25 at the peak, then I may have a decrease in my cardiac filling, my venous return, because a lot of it is just getting flushed out of the thorax. So I need to adjust that with a bit of my cardiac output as well. So the general consensus is that if you keep your plateau pressure below 30, if you can keep it below 25, it does not affect the right ventricular filling and the right ventricular function. But if it affects more than 25, then it can create, if it has more than 25 or more than 30, and sometimes you may have a decrease in the cardiac output, and thereby you may actually increase the dead space ventilation and worsen the VQ mismatch. Another problem with increasing the respiratory rate could be that my inspiration and expiration are both processes which take some time. So my inspiration is usually half the time of my expiration. If I increase the respiratory rate and my lungs don't get enough time to breathe out, what may happen is that before the full breath was out, you may have a next breath being delivered in, and that may lead to a dynamic hyperinflation of the lung, which would actually cause something called as an auto PEEP, and thereby causing a worsening of the oxygen, worsening of the ventilation, and if not picked up quickly, would increase to such a proportion that my right ventricular pressure would be essentially outmatched by the intrathoracic pressure, and there may be no cardiac output happening at all because there will be no venous return coming to the heart. So you need to be very, very careful. Ventilators are not machines which are simple and which attach it and forget it. You need to frequently keep on looking at the ventilator parameters to make sure that you are not doing any harm to the ventilator, to the patient.